All right, this afternoon's session will involve presentations on GU malignancies, and first off, we have Dr. Evan Yu from the University of Washington to talk with us about metastatic prostate cancer management with novel agents. Dr. Yu, welcome.
All right, well, thank you very much. It's a real pleasure to be here today. I feel real fortunate in this field right now because prostate cancer has been a field that's changed dramatically in the last 4 or 5 years. And the title of this is purposeful because for the longest time, only agents were being developed for castration-resistant prostate cancer. There are multiple new therapies now for metastatic hormone-sensitive disease as well. So I'm going to talk a little bit about both. I'll start with castration-resistant prostate cancer, but work my way back. So a lot of discussion topics. This is, like I said, this is a hot field right now. There's a lot of things to cover. I'll just go over the basic clinical states in prostate cancer, some definitions and mechanisms of how castration-resistant prostate cancer develops. I'll talk about some of the newer hormonal therapy options, namely abiraterone and enzalutamide. Sequencing of agents, there's not a lot of data out there right now. There's some retrospective analyses, but people basically doing things based off of some common sense. But that being said and done, there's a little bit of data out there. Biomarkers, this is a hot field right now. There's a lot of biomarkers in development, and the hope is that we will have predictive biomarkers in the near future for prostate cancer. And then I'll talk about some drugs that I consider more niche drugs, and the reason I use that term niche, it's not derogatory, it's just meant that they're not drugs that kind of apply to the broad patient population, the every patient. They're drugs that you have to think about the eligibility criteria like a clinical trial. Obviously, a lot of new data with chemotherapy, and then this leads into the fact that we're seeing more and more of this neuroendocrine small cell and aggressive variant prostate cancer. And throughout the whole talk, I'll sprinkle clinical trials in there and some propaganda from some trials that we have in our institution. So this is a slide, or something like a slide that you've seen before, which covers the clinical states in prostate cancer. This is unique in the fact that unlike most cancers where you have localized disease and metastatic disease, we have PSA. And what PSA has created is multiple different disease states where you have a rise in PSA. You know you have micrometastatic disease, but you can't necessarily see it on a scan because the PSA is still more sensitive than our imaging modalities. But as you can see here, you can start off with clinically localized disease, march forward into the largest disease state, which is biochemically recurrent prostate cancer with just a rising PSA and nothing on scans, and then differentiate it into 2 different pathways. You can develop metastatic hormone-sensitive disease, or some people get treated with biochemical recurrence with androgen deprivation therapy, and when you become castration-resistant, you have what people call non-metastatic, or NM-CRPC. M0-CRPC is another term that people use. But of course, this all meets eventually at metastatic castration-resistant prostate cancer, which is where most of the new drugs are FDA approved. So, basic definitions, castration-resistant prostate cancer is just a patient that's on androgen deprivation therapy, has a castrate testosterone level, and has either serially rising PSAs, worsening bone scans with new convincing lesions, or progression by RECIST criteria, new soft tissue lesions, or growth of soft tissue lesions. And I think the key thing to point out is the older terms androgen independent, hormone refractory, they're all really misnomers. There's a lot of data that I'll show to show that really the androgen axis is still very active in castration-resistant prostate cancer, so we have to consider these terms very carefully. This right here just points towards some of the mechanisms of castration resistance. So on the far left, you see androgen production by the adrenal gland, and some data from Jim Muller's group at Roswell Park and Pete Nelson's group at the University of Washington have really shown that the tumor probably makes its own fuel, makes its own androgens. All the enzymes in the adrenal gland that lead to upregulation and production of androgen synthesis from cholesterol, they're really all there and upregulated in the tumor itself. So you expose the tumor to androgen deprivation therapy, all these enzymes start to upregulate, and they're probably making their own androgens as well. So not a foreign concept. I mean, in breast cancer, we've had aromatase inhibitors around for a long time, so it all makes sense why abiraterone would work in this disease as well. Androgen receptor overexpression. This is probably a lot more common than we really realize now. it totally makes sense as well that androgen copy number would increase due to overexpression in a hormone-resistant or castration-resistant state. Androgen receptor splice variants, this is something I'll talk more extensively about, but I'll just tell you that these are felt to be constitutively active and may not require the ligand binding domain at all in the androgen receptor to be active. So you can be active even without androgens. But again, I'll talk more about that. AR mutants are less common, but they do occur. There are mutants that lead to even, promiscuous binding of steroids, glucocorticoids to the androgen receptor that can stimulate the androgen receptor. So, these can be mechanisms of resistance as well. And of course, many downstream signaling pathways. This is where the field's been for quite some time, and unfortunately, we haven't found inhibitors downstream to be efficacious yet. PI3 kinase inhibitors, these have mTOR inhibitors even have been tested in prostate cancer. It's not that they're not efficacious, it's just we may not have studied the right patient populations. But again, signaling crosstalk with other pathways, there's a lot of intersection in intracellular signaling with other pathways. And then upregulation of androgen receptor cofactors. This is really kind of a new field. There's some agents that are coming out that will address that as well, and we'll talk a little bit about that later. So what I'll really start off with are kind of the drugs that I think most patients will see, which is once you get metastatic castration-resistant prostate cancer, there are some potent hormonal therapies, and probably for those patients that have metastatic CRPC, the first-line therapy should probably be one of these potent AR-targeted therapies first line. Of course, there are exceptions, and I'll talk about those exceptions. So one of these agents is abiraterone. I mentioned it already briefly. This works by inhibiting CYP17 lyase. This is an enzyme that leads to production of testosterone, of androgens down on the bottom. You can see the good old salt, sugar, sex pathways there from med school or college biochemistry, and you can see how abiraterone can inhibit synthesis of testosterone very potently. Now, the first trial was in the post-chemotherapy setting. It was the Cougar 301 trial, and showed an improvement in overall survival and radiographic progression-free survival. Where we're using it mostly now is in the pre-chemotherapy setting, and this is because the Cougar 302 trial showed a significant radiographic progression-free survival benefit and a reduction in deaths, overall survival benefit. Now, they unblinded the study early at the interim analysis and allowed for crossover. And even after crossover, meaning the patients who are on the control placebo and prednisone arm that crossed over to abiraterone, even after crossover, on final analysis, there still was an overall survival benefit for those who got abiraterone in that study arm who got it right up front. So that being said and done, this has really confirmed a survival benefit even in the pre-chemotherapy environment. Then, of course, there's enzalutamide. And so one, like abiraterone, inhibits synthesis of the ligand, testosterone. Two, enzalutamide just inhibits further downstream, inhibits the actual receptor, androgen receptor, where testosterone, dihydrotestosterone bind to. And it's not like the older AR-targeted, anti-androgens. It's not like nilutamide, flutamide, bicalutamide. Those are agonists, antagonists. They bind reversibly to the androgen receptor. Enzalutamide binds irreversibly to the androgen receptor, does not allow intercalation into the nucleus, does not allow binding to chromatin, to DNA, so it can act as a transcription factor. So it really, really is a potent antagonist. There's been no agonistic properties in preclinical models, so it makes it unique and highly efficacious. Similar to abiraterone, the initial trial was in the post-chemotherapy setting and showed a survival benefit. But again, we're mostly using it in the pre-chemotherapy setting here because the PREVAIL trial data came out. Radiographic progression-free survival, dramatically different, and overall survival also significantly different. I will point out, it's hard to compare between trials, but the comparator arm on this trial truly did receive placebo. On the abiraterone trials, the comparator arm received prednisone and placebo, and prednisone has activity, probably significant activity in about 20% of metastatic castration-resistant prostate cancer patients. So people always try to get me to compare these two trials and say which one's better. I don't know which one's better, but I do know that the trials were designed somewhat differently. So the natural question, which should go first? And there's really no data to guide us. And they say, well, Evan, hey, you use these drugs a lot. You should know. I can't tell the difference. I use these drugs both a lot, and I can't tell any difference. So there's really no data to guide us choosing between abiraterone and enzalutamide. But there are toxicity considerations. Abiraterone can lead to transaminitis. It can lead to fluid excess because of mineralocorticoid excess. You're shunning away from androgens and you're shunning towards mineralocorticoid production. And the prednisone with abiraterone can lead to hyperglycemia, so if you have a poorly controlled diabetic patient, that could be an issue as well. With enzalutamide, of course, there's a seizure risk. It's a small seizure risk, less than 1% for sure. And in the earlier trials, the trials that test it in an earlier disease setting, there really aren't significant seizures. But I think the bigger concern is fatigue. And elderly patients have more problems with fatigue. It's felt this might be a neurocognitive fatigue. We don't exactly understand the mechanism, but it's felt that it crosses the blood-brain barrier, and androgen receptor may have interaction with GABA receptors in the brain. So again, there is a higher fatigue rate. There's a higher fall rate and higher hip fracture rate if you look at the package inserts. So a lot of this goes along with fatigue, so you have to carefully select patients. So if I have somebody that comes in and has active hepatitis and transaminitis, I'm probably going to go with enzalutamide, not abiraterone. If I have somebody that comes in and already has kind of a diminished performance status and is older and fatigued, or let's say they've had a lot of strokes and is at higher risk of seizures, I'm probably going to go with abiraterone rather than enzalutamide. So really, I make my decisions based on toxicity considerations. There are some situations where the first agent should not be a hormonal agent, and I think that those with really rapidly progressive disease, significant symptoms, visceral metastases, these patients might do better with introduction of chemotherapy earlier. Now, we used to just use docetaxel, but there's more and more data coming out for use and introduction of platinum therapies like docetaxel, carboplatin, etoposide cisplatin, and those with neuroendocrine small cell, and we really are seeing more and more of this. It might be because of the potent hormonal agents we're using that we're driving more resistance pathways down that neuroendocrine phenotype. So, again, it needs to be considered and carefully studied. So how well does one agent work after the other? So let's say you start with abiraterone. Should you go to enzalutamide next? You start with enzalutamide. Should you go to abiraterone next? Not good data. There's no randomized control data. There's a lot of retrospective small analyses, 30, 50 patients out there. It's incomplete information. Usually heavily pretreated post-chemotherapy populations. Heather Chang, who was one of my fellows, who's now on faculty at the University of Washington, she did a really nice analysis, a 7-center analysis, about 370 patients, probably the biggest analysis out there, and showed that after abiraterone, if you go on to enzalutamide, you'll still have responses in the 20-30% range, significant responses. But that being said and done, it's not everybody. It's actually the minority of patients, and so it needs to be considered in the equation when you have a patient. Certainly, there are a lot of patients resistant to go on to chemotherapy. They're totally asymptomatic, probably fine to switch and go on to the next hormonal agent. If they're one of that 30% or so, hey, that's great. But there's other patients that are progressing more quickly. You probably want to move on to something with a very unique, different mechanism of action then. And I think the key thing is that even if patients do respond, most responses are not incredibly long-lasting. So what we need in the field are clinical trials to answer this question. Let's say you get a potent hormonal agent first, abiraterone or enzalutamide, you progress. What should you do? Should you switch to the next one, or should you go on to chemotherapy? And so this PRIMCAB study tries to answer that. This is a study for patients felt to have basically progressive disease or primary refractory disease to either abiraterone or enzalutamide. That just means they progress within 6 months of the agent, and they're randomized to either switching to the other hormonal agent or to cabazitaxel, 25 milligrams per meter squared with prednisone. You might ask, why not docetaxel? Well, no one's funding docetaxel these days and supporting that study, so logical it would be cabazitaxel. So shout out to my Sanofi rep out there. I don't know if there is one, but anyhow, point being is I'm just saying it how it is that clinical trials are expensive and somebody has to support the study, and so this is being supported by Sanofi, and so it is for switch to cabazitaxel. But cabazitaxel obviously is a good drug that shows survival benefit after docetaxel, and there are trials that are trying to move it up earlier. This primary endpoint is radiographic progression-free survival. It's almost 300-patient study, and I think this is the type of study the field needs to help us be able to answer the question when you progress on one hormonal agent, which is what most patients get first, what do you do next?
Not just PSA progression.
No, they leave it up to you. So it's primary refractory disease, progressive disease within 6 months of AR targeted therapy. So for eligibility, they kind of usually, if you have new imaging findings, symptomatic progression, PSA progression could be allowed. Certainly, I think that's included as well. But it's a good point because all the abiraterone and enzalutamide trials did not take patients off for PSA progression. They took them off for radiographic progression or symptomatic progression. Of course, however, those trials allowed patients on for PSA progression, though. So again, there's a little bit of contradiction in how we do things in prostate cancer right there. Now, one other technique is combination therapy, and I think this is very rational right now. Most cancers use combination therapy. We tend not to in prostate cancer, although we're moving that direction. So this is an alliance group trial, and these are just example trials. There's a lot of trials going on out there, company-sponsored trials as well, but I'm showing a cooperative group trial through the alliance group that is going intergroup, and this is basically men with metastatic, castration-resistant prostate cancer randomized to enzalutamide or enzalutamide with abiraterone, again, combination, and it's overall survival. And I think that's rightfully so because it needs to be overall survival there. If you have a combination, maybe you get radiographic progression-free survival benefit, but if it's more toxic and a lot more expensive, boy, I really got to see a really, really meaningful endpoint here. So I think overall survival's the right endpoint here. Certainly, I think the trial design could have also had an abiraterone alone arm, and ideally would have sequencing of abiraterone after enzalutamide or enzalutamide after abiraterone, because if the sequencing does just as good as a combination in terms of survival, I'm not so sure that's, any benefit to doing the expensive combination. But that being said and done, that kind of trial requires support as well, and so it's a cooperative group trial, and this is what they could pull off. So now, my thought is what about chemohormonal therapy? And we're going to talk about chemohormonal therapy for hormone-sensitive prostate cancer because there's a lot of new data out there in this setting. But it makes sense for metastatic castration-resistant prostate cancer to take drugs with different mechanisms of action along different axes and combine them together as well. And so why not take one of the newer potent hormonal agents like enzalutamide with one of the newer potent chemotherapies like cabazitaxel and combine them together? And so we're doing this trial at the University of Washington. It's an investigator-initiated trial. It's in combination or in collaboration with Oregon Health Sciences, hence Tom Beer and Julie Graff at Oregon Health Sciences. Heather Chang is our junior investigator running this trial. And again, it's basically to see whether the combination has significant efficacy since, chemohormonal therapy seems to have significant efficacy earlier on in the hormone-sensitive disease state. It does make some sense to test this as well in the metastatic disease state. So I'm going to move on to the biomarker section, and this is on splice variants, AR splice variants. And just so you know, there are a lot of different splice variants. It's not all AR-V7. So this is the most abundant AR splice variant, and it's probably about 50% of all splice variants, maybe more. The key thing is, as you can see here, what happens is you're splicing out the ligand binding domain. So you might say, okay, I have no ligand binding domain. Well, testosterone has nothing to bind to. This thing shouldn't work at all. It should do nothing. But here's the thing, it has the ability to heterodimerize, and it can heterodimerize with other full-length androgen receptors. It can heterodimerize potentially with other splice variants, and then they can activate and translocate in the nucleus and do all the nefarious stuff that androgen receptors do in the prostate cancer state. But that being said and done, it can do it even without androgens. So it's basically, I guess, different biology, but one way to think about it is a little bit like KRAS and cetuximab, and how KRAS, if it's mutated, it's going to be activated downstream, constitutively active, even without need for EGFR upstream of it. So a similar type of thing. It's just going to be constitutively active. The interesting thing about this is that it's upregulated very quickly. You give abiraterone, you give enzalutamide, 36, 48 hours, you start to see a lot of androgen receptor splice variants. But another interesting thing is it's still a minority compared to the full-length androgen receptor, which should lead to some healthy skepticism. I'm going to show you some really impressive data from my colleagues at Johns Hopkins, but this is not validated yet in terms of the predictive capability. So this is the data that came out in the New England Journal. Manuel Antanarakis at Hopkins published it, and what he did was a simple study. He used an adenogene technology to pluck circulating tumor cells and drop specific PCR primers. or primer specific to full-length androgen receptor and primer specific to the AR splice variant. It obviously lacks the entire ligand binding domain, so it's easy just to design specific primers. And what he found is that those that were ARV7 positive, if they found that splice variant, those patients just didn't respond to abiraterone. And that being said and done, the PSA progression-free survival and progression-free survival significantly different as well if you express ARV7 versus if you don't express ARV7. Similarly, did the same thing for enzalutamide before treatment, of course. If you expressed ARV7, you're just generally not going to respond well to enzalutamide. Similarly, you're going to have worse outcomes in terms of PSA progression-free survival and progression-free survival. So then he said, what about taxanes? Now, you might say, this is a totally different mechanism of action. It has nothing to do with androgen receptors. But if you live in an AR-centric world, like a lot of people in my field do, there are scientists who say that actually taxanes may mediate their effect, via AR. And how they might do that is androgen receptor has to traffic into the nucleus, and taxanes work via microtubules. So if you ignore the other effects of taxanes, you could say that, well, what you're really doing when you're giving docetaxel is you're inhibiting androgen receptor shuttling into the nucleus. And so this is interesting because ARV7, remember, the ligand binding domain is spliced out, but so is the hinge region. And the hinge region is what binds to the microtubules. So they've said, well, maybe ARV7 does have an effect here. Now, the interesting thing is in a xenograft model that we have, the LUCAP 23.1, which was developed at the University of Washington, they found that actually in this xenograft model that even though ARV7 lacks a hinge region and it doesn't bind to microtubules, it still somehow got into the nucleus. So they're like, maybe this does have some predictive ability and might predict for lack of response to docetaxel as well. But that's not what the data necessarily showed. You can see by the waterfall plots, some patients that were ARV7 positive still had significant PSA declines and responses to docetaxel. Now you see the curve still split, and I think that this probably clearly has some prognostic capability, ARV7. The real question is it predictive? And the early data shows that it might be predictive for lack of response to abiraterone, to enzalutamide, but probably not as predictive for lack of response to docetaxel. Of course, larger numbers need to be tested. There needs to be really a randomized trial to really validate it because you can't determine predictive ability in single-arm trials. You have to have a randomized trial with different arms to really determine predictive ability. So this is not ready for prime time yet, although everybody keeps talking about it, and I think everyone needs to get on the same page and figure out how we're going to get this or test it to validate it so that we can get it prime time if it really is predictive. So there's already trials and drugs being developed to target ARV7. That's natural, right? There's a drug called EPI-506, I think, that's made by ESSA Pharmaceuticals that targets the amino terminal domain. So not the carboxy terminal domain where the ligand binding domain is, but the internal domain of the androgen receptor. And so one might say, well, maybe this works not only for full-length androgen receptor, but also for AR splice variants. So that might be really cool, and Bruce Montgomery's leading that nationally and internationally, that phase 1, which is getting kicked off. But we also have a junior investigator named Mike Schweitzer, who we recently recruited from Hopkins, who's looking at niclosamide. So you might say, what's that? Well, there was a screen done looking at ability to inhibit ARV7-mediated protein expression. And they looked at over 1,100 FDA-approved agents, and they found this drug called niclosamide, which most people probably don't know what it is, but it's used in dogs and was approved to inhibit helminthic infections in dogs. It's hard to get a hold of now, but I think Bayer still makes it in the United States. That being said and done, it decreases ARV7 protein levels, and it's possible through proteasomal degradation. But full-length androgen receptor is not targeted at all, although it does have other effects, downstream effects inhibiting NF-kappa B, the Wnt beta-catenin pathways, and mTOR signaling. Here's some preclinical data to show that when you combine niclosamide with enzalutamide, you get some synergistic activity, you get much smaller tumors, you get much reduced growth patterns there with the combination. So here's a trial, and this is going to kick off real soon. This, again, being led by one of our junior investigators, Mike Schweitzer. There are some problems with niclosamide. It has limited absorption and bioavailability, so we're trying to go with high-frequent dosing in our phase 1 trial. But we're going to measure circulating tumor cells, and we're going to PCR for ARV7, just as they did in the Hopkins trial. It's going to be a post-abiraterone patient population, which has a reasonable amount of ARV7, And then we're going to combine enzalutamide with niclosamide. And the primary endpoint is not PSA decline, because we expect a reasonable proportion will get PSA decline with enzalutamide, but we're looking to eradicate those ARV7 populations. And we know that enzalutamide shouldn't eradicate it. Enzalutamide should upregulate ARV7, but niclosamide should eradicate it. So of course we're going to look at clinical responses at PSA, progression-free survival as well, but we're going to be mostly doing a PK/PD study looking at the pharmacokinetics of niclosamide and looking at eradication of the androgen receptor splice variants. And so we're going to have 3 different cohorts with different dosing. So again, just kind of a homegrown trial, but addressing something that's pretty interesting and a potential resistance mechanism in our field right now. Okay, I'm going to move on to an immunotherapy section. So this is starting to get into the niche drugs. I'm going to be brief with this. Is we know the survival benefit with Sapulous-LT. We also know that there are challenges with Sapulous-LT. We don't see PSA declines. We don't see improvement in progression-free survival. And so, you know, there are some real challenges there. The treatment is quick. It's done in 5 weeks, and there's very few side effects. But how do we select patients? How do we determine who's responding? We don't have something like a PSA. So I'm reasonably selective. You know, the label is for those with metastatic, asymptomatic, or minimally symptomatic patient populations. I generally tend to give it to those that are asymptomatic, and I tend to give it to those with lower disease burden. And so they did this post hoc analysis looking at the PSA quartile at baseline. As you can see, these are 4 groups, obviously quartiles. The best group had a PSA less than 22. The worst risk group had a PSA greater than 134. But it's broken down into quartiles, and I just draw your attention down to the hazard ratio at the very bottom. And as you can see, the lower the baseline PSA, which is probably a marker of disease volume, the better the hazard ratio. So the difference between Sapulous-LT and control was greater. That makes a lot of sense because it's immunotherapy. The survival curves don't split for 6 months. Probably takes a while to kick in. The immune system's most competent in patients with earlier disease. And so it makes sense that if you have somebody with lower volume disease, lower burden disease, that those patients probably get better benefit. So it's not for everybody, certainly not for somebody with symptoms already, but it's for patients who probably have lower volume, more indolent disease. What we're trying to do is develop more biomarkers. And there are some immune-mediated biomarkers that tend to correlate with response. If you look at antibody responses against PAP, prostatic acid phosphatase, which is what Sapulous-LT is made to target initially, that those with higher antibody production seem to have a better overall survival. There's also data that shows that patients that get immunotherapy that have rushing T cells into the tumor, TILs, tumor-infiltrating lymphocytes, that those patients have a better prognosis as well. So we have a very robust metastatic biopsy program at the University of Washington. So what we're doing is we're doing metastatic biopsies before and after Sapulous-LT. We're measuring T cell infiltration in the tumor. We're looking at all the antibody responses. We're also looking at antigen spread. So the idea that when you kill a cancer cell, that other antigens are released, they get uptaken by other immune cells, they get presented by antigen-presenting cells, and then all of a sudden down the road, you're now targeting multiple different antigens, not just PAP, but you can target multiple other cancer antigens down the road as well. And there's some early data that shows that with Sapulous-LT, if you have greater antigen spread, you're gonna have better outcomes. So we're gonna do T-cell receptor sequencing from the data, from the tissue and the blood, to look to see whether there's increased antigen spread here. So now on to another niche drug, radium-223. Now the reason this is a niche drug is you have to have bone metastases and no visceral metastases, and you have to have symptomatic bone metastases, so pain. So this was the Alsimca phase 3 design. This was randomized to radium-223, the alpha-emitting radiopharmaceutical, versus placebo, best standard of care for up to 6 treatments, 6 injections, and what they showed here is a significant overall survival benefit. There also was improvement in time to skeletal-related events, time to pain, et cetera. So there were multiple endpoints. But I think the important data here is that there's some data that shows that the more cycles you get, 5 or 6 cycles, treatments, that those patients will do better than those that get fewer treatments. You know, you get 1 or 2, you get 3 or 4. That's not as good. You want to be able to give the full 6 cycles. So the question comes, when should I give this? It's for bone metastatic symptomatic castration-resistant prostate cancer. Should we give it before chemo? Should we give it after chemo? Well, the nice news is that this trial wanted patients to have either received docetaxel or be ineligible for docetaxel, I don't know who that is, or more likely refuse docetaxel. And it ended up being something like a 60-40 split, being post-docetaxel or pre-docetaxel, and they were able to show statistically significant survival benefit whether you were pre or post-docetaxel. So what do I try to do? I try to give it earlier. And it makes sense to me because my goal is to give my patients as many life-sustaining, life-prolonging therapies as possible. And if I want to do that, I don't want to lose options. Now, it's just real practical why I give it earlier. If I give it earlier, I'm more apt to be able to finish the full 6 cycles, versus if I give it later, they might be in pain or moving on to hospice already. If I give it earlier, they're less likely to have visceral metastases. If I give it later, the visceral metastasis rate increases. If I give it earlier, there's less likely to have problems with their counts. And nobody cares what someone's counts are if I give them chemotherapy. But our institution and insurance companies certainly care and might not pay if they meet the approved indication. And that requires your ANCs greater than 1,500, hemoglobin's greater than 10, and platelet counts over 100,000. So if I give this earlier and later on I want to give chemotherapy and their platelet count's 75,000, well, that's up to my judgment. I can give docetaxel because it's a cheap drug now. But if I give docetaxel first, I can't give radium now all of a sudden because their platelet count's 75,000. And so again, if I'm looking out for the patient to try to get them as many life-prolonging therapies as possible, I tend to try to give this earlier rather than later. Now, we're doing some research with this as well. We're trying to study mechanisms of resistance. So the point is that this is an alpha-emitting radiopharmaceutical that induces double-strand DNA breaks. And so, what should happen is DNA damage proteins should be upregulated, and there might be mechanisms of resistance to this. So we're looking at mechanisms of resistance, things like BRCA2, BRCA, things like ATM, ATR, and especially since there's ATM inhibitors being developed right now, we're looking for potential novel springboard combinations or sequencing therapies. How we're doing this is because we have a very robust metastatic biopsy program, we're trying to be more selective with how we biopsy patients. So we're starting to do more PET imaging. And with that PET imaging, what we're able to detect is a lot of heterogeneity of disease. So you can have patients with a decreasing PSA or an increasing PSA, but some lesions are getting better, other lesions are getting worse. Well, if I'm looking at drug resistance, I don't want to biopsy the lesions that are getting better. What we're doing right now is we're picking a lesion to biopsy and we're going back to that same lesion. But we don't truly know if that lesion is responding or not. So we're starting to use PET to select lesions based on what it looks like on PET, and we want to select lesions that are getting worse, or biopsying some lesions that are getting better as well, but we run the risk of not getting tumor if we really have induced a lot of apoptosis in those cells. So we're doing PET imaging beforehand, we're given radium-223, and then we're doing PET imaging and selecting the lesions that are most resistant and assaying them for double-strand breaks, gamma-H2AX, and looking at basically the BRCA pathways, ATM, ATR, trying to look for novel paired combination therapy down the road with radium. So, on to the next topic. When should we give chemotherapy? Should it be given earlier? So here's the data with CHAARTED. This is the data that everyone's excited about, just came out in the New England Journal. New metastatic hormone-sensitive prostate cancer patients randomized to 6 cycles of docetaxel and ADT, androgen deprivation therapy, versus androgen deprivation therapy alone. Here's the money slide. 13-month median survival benefit. Most of the patients who died of prostate cancer. Most of the patients who died had high-volume disease. And you might say, well, what's high-volume disease? In this study, they defined it as either visceral metastases or 4 or more bone metastases and at least 1 outside the axial skeleton. That means not the vertebral bodies, not the pelvis, but appendicular skeleton. Femur, humerus, ribs, skull, something like that. And if you look, this is a 17-month median survival benefit if you had high-volume disease. If you had low-volume disease, data's not mature. Hazard ratio looks similar. It might end up being a significant benefit, but the data is just not mature. These patients enrolled later on the trial. They're going to live longer. We have to wait and see. Now, this year at ASCO, there was a confirmatory study, the STAMPEDE trial, even larger trial, run at the UK. And you can see, like a lot of UK studies, they do a ton of different study arms. But we're going to focus in on the ADT arms and the ADT plus docetaxel arms. I'll just tell you right off the bat, because I'm not going to show you the data, zoledronic acid added no benefit. There's been studies that showed it adds no benefit for hormone-sensitive disease in terms of skeletal-related events, and no benefit in terms of survival here. So it really should be retained until the patients have castration-resistant bone metastases to prevent skeletal-related events. So here's basically docetaxel, which is the upper red curve, and standard of care is androgen deprivation therapy. Median 10-month survival benefit in the entire population. Now, this study was interesting. It wasn't all new metastatic prostate cancer patients. They did allow some with localized disease but high-risk features, node-positive disease as well. Here's the forest plots. If you look there in the middle, in the red, the M1 metastatic disease population, far to the left. M0, which was 39% of the patients. It was 61% breakdown had metastatic disease, 39% just had high-risk localized disease. Again, can't tell because the data is not mature. But if you exclude all the patients that had localized disease and just include the metastatic disease population, median survival benefit is 22 months. Very dramatic data. So I think it's a no-brainer. Metastatic prostate cancer, hormone sensitive. We're seeing more and more of it because of the screening guidelines for PSA, the grade D or whatever the U.S. Preventative Task Force gave it. There's more and more people presenting with de novo metastases. Docetaxel up front, especially for high-volume disease. I think low-volume disease is still questionable. Enzalutamide. There are trials going on here. Chris Sweeney in Australia, they're running this trial, which is basically adding enzalutamide to the new M1 patient population. Docetaxel is dealer's choice. They figure it'll work out in the randomization, but overall survival is the primary endpoint. This is one of many trials going into this space. Just about everybody's going into this space right now. SWOG has a trial with TAX 700, the only TAX 700 trial, and we're eager to see those results in the very near future. So I want to move on to the last section. I think I'm running over a little over time, but like I said, there's been a lot of changes in prostate cancer, so it's a big topic. I want to talk a little bit about platinum chemotherapy because there's more and more of this aggressive variant in neuroendocrine prostate cancer. So Anna Aparicio published this data. She's from MD Anderson in the Clinical Cancer Research, and it's probably hard to see, but it was based on 7 criteria. You either had small cell histologic evidence of small cell, exclusively visceral metastases, lytic bone metastases rather than blastic, like most prostate cancer metastases are, bulky lymph nodes greater than 5 centimeters, or low PSA in the presence of kind of high-volume disease, presence of neuroendocrine markers like synaptophysin or chromogranin A on histology, or short interval until androgen-independent progression. Any one of those 7 criteria, the ones that seem to have the most strength were the bulky lymph nodes and neuroendocrine markers, but it led to better outcomes for those patients if they added carboplatin to the regimen. So they got carboplatin, docetaxel. So if I'm seeing patients that fit these criteria and they have this aggressive variant type of prostate cancer, I'm starting to introduce more chemo earlier and carboplatin as well to chemo. Now, on that study, if carboplatin docetaxel didn't work, they switched over to etoposide cisplatin, so a standard small cell regimen. But this brings to the question, when to perform a metastatic biopsy? Bulky visceral metastases, liver mets, bulky lymph nodes, low PSA in the setting of high-volume disease, lytic bone metastases rather than blastic, primarily lytic. And I do a lot of metastatic biopsies just for research and also for clinical indications here. So a picture of small cell, real homogeneous. It's probably a mechanism of resistance to androgen deprivation therapy. Really bad outcomes, much worse than standard prostate cancer. And as you can see, this is a little different than lung small cell, not a lot of paraneoplastic syndromes, but we do treat it just like lung small cell. So when we really see small cell neuroendocrine, we give a platinum doublet, usually etoposide cisplatin. If it's a small cell prostate cancer, pure small cell. If it's not a pure small cell on histology, then I'll kind of call it this aggressive variant or anaplastic, and then I'll use something like carboplatin docetaxel. So to wrap up and then go on to a few audience response questions that I have, we should generally start with one of the newer potent hormonal therapies. Immunotherapy for suppressor T could be considered for those with kind of lower volume asymptomatic metastatic castration-resistant prostate cancer. If you have symptomatic bone metastatic castration-resistant prostate cancer, you probably should try to give radium earlier rather than later. There's no definitive evidence as to how to sequence therapies yet. It's still kind of common sense. ARV7 is a potential predictive biomarker, but it needs to be validated. There's a lot of clinical trials underway. There's trials moving these agents earlier. There's trials doing combinations, and there's trials trying to target mechanisms of resistance to these agents. And chemotherapy should certainly be used for at least high-volume metastatic hormone-sensitive prostate cancer, maybe even for low-volume. And even for metastatic castration-resistant prostate cancer, we need to think about chemotherapy as well, and platinum potentially earlier, since there's more of this neuroendocrine phenotype out there. So I just want to acknowledge some of the fellows and trainees that I have, some of the people, some of the work that was done here. George Ramos, I forgot to mention him. He's a fellow working with me on that PET biopsy study with radium-223, but obviously a lot of people, other people to acknowledge, and funding sources that are helping to support some of these studies here. So let's move on. The audience response questions. I'm going to kick this in order here. Basically, the first question, this is a 62-year-old Caucasian male, metastatic prostate cancer, a couple bone metastases, right ilium, L4 vertebral body, has been on LHRH therapy for 4 years. PSA starts to rise. It was undetectable. Now it's 0.8. Now it's 1.4 over the course of 6 months. Asymptomatic. Restaging scans show no new metastases. Your treatment options. Keep in mind, there's maybe multiple correct answers. There's usually a few that are also incorrect, so feel free to select. Okay, so I can't see what all the answers are. Oh, I guess I could probably move this here, but we have here, most people selected abiraterone and prednisone. I think that's a very reasonable response. Enzalutamide is fine as well. Radium-223, now this patient is asymptomatic, so he's not eligible to receive radium-223. It's not that it doesn't work in asymptomatic patients, it just hasn't been tested. So in the future, we may see data to show the ability to use radium-223. Sapulosel T, that's a very logical choice because this guy has pretty low volume disease and low PSA levels. I probably would have gone there, but I think abiraterone or enzalutamide are reasonable. You certainly could give docetaxel or prednisone, but I would tend to reserve it for a later setting. Okay, next patient is a little different, has innumerable bone metastases, multiple pelvic and retroperitoneal lymph nodes developed, rapid rise of PSA, 0.5, 4.8, 29 over the course of 3 months. He's on androgen deprivation therapy. He's clearly castration-resistant. He's now starting to get bone pain. Your treatment options include abiraterone, prednisone, enzalutamide, radium-223, sapulosel T, docetaxel, or prednisone. Go ahead and answer. Okay, here. So more people selected abiraterone. I think that's, again, a reasonable treatment. It has symptomatic benefit as well. Remember, this guy has pain. Enzalutamide would be reasonable as well. Radium-223 would be possible as well. Keep in mind, though, he does have multiple retroperitoneal lymph node metastases. His PSA is rising fast. I'd be worried that it might not target that. Radium-223 also doesn't reduce bone pain incredibly rapidly. It takes a few months for it to really happen. This is not a sapulosel T candidate. His disease is moving too fast, and he also is symptomatic, so I wouldn't have gone with sapulosel T, and certainly docetaxel or prednisone is reasonable as well in this patient. On to the next case. This is a 62-year-old Caucasian man, metastatic castration-resistant prostate cancer, lots of osteoblastic metastases. PSA has been 0.4 to 0.9 while on abiraterone and prednisone. Last couple months complained of abdominal pain. Restaging CT show multiple new liver mets, new lytic bone metastases. Do you give him enzalutamide, radium, docetaxel, docetaxel with carboplatin, topicide with cisplatin, or biopsy of liver metastasis? Too many choices? I heard that. You know, oh, that's not fair. Well, okay, let's just see. So here's the problem is I would have gone with the option that you couldn't select. So biopsy of liver metastasis, and I see many of you were trying to select that. That's okay. It's okay to proceed with docetaxel or carboplatin or even etoposide with cisplatin, but I think it would help guide me. If I saw pure neuroendocrine small cell here, I'd probably go with the topoisomerase cisplatin. If I didn't, then I would call this more an aggressive variant and go with docetaxel or carboplatin. It's not wrong to go with enzalutamide or docetaxel or prednisone, but I think the issue here is this guy's kind of declaring that he's kind of headed down that aggressive variant phenotype there. So I would have gone more with one of the chemotherapies and perhaps thrown a platinum in there as well, but would have biopsied him first. And sorry, there are too many choices here. So here we have 5 choices again. This is a 62-year-old who basically presents with new bone metastases. He has not yet received androgen deprivation therapy. His PSA is 121. Do you give him leuprolide? Do you give him biclutamide with leuprolide, leuprolide, docetaxel, leuprolide, docetaxel and prednisone, or docetaxel or prednisone? Okay, so let's go through these choices. So I wouldn't give him leuprolide alone. He needs some sort of anti-androgen because he has diffuse bone metastases and diffuse bone pain, and you don't want him to get a testosterone surge, a flare response, and have pain. So biclutamide followed by leuprolide would have been the response a little over a year ago. Biclutamide, leuprolide, docetaxel a week later is absolutely fine. Biclutamide, leuprolide, docetaxel, and prednisone is probably fine as well. But the CHAARTED trial, and I didn't have time to mention this, I should have mentioned this, but they didn't use prednisone in the CHAARTED trial. So it's nice to be able to get rid of the prednisone, so I tend not to use prednisone in the hormone-sensitive setting. And docetaxel and prednisone alone probably shouldn't be given. You got to get him androgen deprivation therapy as well. So I think either 3 or 4, but I would prefer to go with 3 there. So thank you very much. I know I ran over time, so I probably should save questions till the end when we do the panel.